Hey everyone, and welcome. If you're getting ready for the AFK exam, you already know that drug-drug interactions are a massive topic. This is where all your pharmacology knowledge really comes to a head. So today, we are going to build a super solid, high-yield framework to help you absolutely master it. So here's our game plan. We'll kick things off with why this is so critical in the first place. Then we'll break down the core mechanism, inducers versus inhibitors. After that, we'll lock in the key drugs with some seriously powerful mnemonics. Then, we'll apply all of that to clinical scenarios you're actually going to see. And finally, we'll wrap it all up with a rapid-fire recap. Okay, let's dive right in. We're starting with the why, because honestly, understanding the stakes is half the battle, not just for your exam, but for the safety of your future patients. Right. So, why do we care so much? It's because these interactions aren't just some abstract concept from a book. They have very real, very serious consequences. An unmanaged interaction can lead to a drug just not working, or on the flip side, it can lead to severe toxicity. This is applied science at its most crucial. And the whole concept really hinges on pharmacokinetics, specifically metabolism. See, most drugs have to pass through the liver, where this big family of enzymes, the cytochrome P450 system, breaks them down. And that metabolic pathway? That's the main stage. It's the battleground where other drugs can jump in and interfere. So this brings us to the two key players in our story, enzyme inducers and enzyme inhibitors. The easiest way to think about them is like the accelerator and the brake pedal for your drug metabolism. And this slide lays out the contrast perfectly. Inducers, they ramp up enzyme activity. They're the accelerator. They clear the primary drug from the body much faster, which lowers its concentration. Inhibitors do the exact opposite. They hit the brakes. They slow down the enzymes, causing that primary drug to build up, sometimes to potentially toxic levels. So let's walk through it. The crucial point is this. You introduce an inducer, right? The liver enzymes go into overdrive. That primary drug gets metabolized way too quickly, its level in the blood drops, and its effect just fizzles out. So, the logical response? You might need to increase the dose of that primary drug to keep it working. And here we see the exact reverse scenario. And it just makes so much sense. An inhibitor drug comes in and slows down that whole assembly line. The primary drug isn't getting broken down like it should, its levels start to rise, and boom, the risk of toxicity skyrockets. So the management here is the opposite. You have to decrease the dose of the primary drug. All right, now for the section I know you've been waiting for. Memorizing these long lists of drugs can be a real pain. So we're going to use two unforgettable mnemonics that are absolute gold for the AFK exam. Okay, for the enzyme inducers, those are the drugs that speed things up. I want you to think of a super busy street during rush hour, and you've got a terrible navigation system. You've got crap GPS. And here is what it stands for. Carbamazepine, rifampicin, alcohol, and this is chronic use, that's key, phenytoin, griseofulvin, phenobarbital, and sulfonylureas. You have got to commit CRAPGPS to memory. These are your absolute key enzyme inducers. Now for the inhibitors, the drugs that slow everything down. For this one, I want you to picture everyone staying home from work or school. They're feeling unwell. The website for that feeling is sickfaces.com. Now, this one's a bit longer, I know, but it is just as crucial. Sodium valproate, isoniazid, cimetidine, ketoconazole, fluconazole, alcohol, see this time it's acute, chloramphenicol, erythromycin, sulfonamides, ciprofloxacin, omeprazole, and metronidazole. This list is just incredibly high yield. So let's see how all this builds into what you'll actually do. Knowing the mnemonics is great, but applying them to real clinical scenarios, that's where mastery really happens. Okay, check out these common antibiotic interactions. Rifampicin, that's the RNR-CRAPGPS mnemonic, is a potent inducer and it can actually make oral contraceptives ineffective. That's a huge deal. And metronidazole with alcohol, this can cause a really severe reaction. Management is simple, avoid it completely. Macrolides like erythromycin can boost warfarin's effect, so you've got to monitor that patient very, very closely. And here are a few more critical ones. A classic exam question is mixing tetracycline, which is bacteriostatic, with penicillin, which is bactericidal. Just don't do it. It torpedoes penicillin's efficacy. Also, you have to tell patients to avoid dairy or antacids with tetracyclines because it just stops the drug from being absorbed.
And our enzyme inhibitors, the macrolides and azole antifungals with statins, that is another hard avoid. The risk of renal failure is just too serious.
Now, let's talk about analgesics. A very common one you'll see is that NSAIDs can reduce the effectiveness of a lot of blood pressure medications. The key here is duration. If you have to use them, limit it to less than 4 days. But with lithium or high-dose methotrexate, NSAIDs are just a no-go. They can cause some really dangerous toxicity.
Aspirin is so important it gets its own slide because its interactions are incredibly significant. With warfarin, the bleeding risk is just way too high. And with sulfonylureas, which are used for diabetes, aspirin can actually displace that drug, causing a patient's blood sugar to drop dangerously low. Both of these are clear cases where you just have to avoid it.
All right, we've covered the why, the how, and the what. Let's pull this all together and synthesize it into a few core principles you can take with you straight into the exam and, more importantly, into your practice.
So let's boil it all down to these core rules. With an inducer, you might need to increase the dose. With an inhibitor, you might need to decrease the dose. Your management hierarchy should always start with avoid if you can. And finally, keep these high-alert dental drugs, antibiotics, analgesics, and sedatives right at the front of your mind.
At the end of the day, mastering this topic goes so far beyond just scoring points on the AFK. It's a fundamental part of providing safe, effective care for your patients. This knowledge, well, it's your professional responsibility, and it's what will make you a diligent and trustworthy clinician. Good luck with your studies.